Hello and welcome to this critical care teaching video on the management of the post-cardiac arrest patient. In this video, we're going to have a little bit of a look at the history of therapeutic hypothermia and cooling. We'll have a look at the evidence and how that's developed over the years, and we'll have a look at current practice. In theory, cooling aims to reduce a lot of the problems that can occur as a result of an ischemic injury to the brain and the reperfusion of the brain. And these include reducing cerebral metabolism and oxygen demand, preventing apoptosis and the cellular influx of calcium, helping reduce the release of excitatory neurotransmitters, reduce inflammation, reduce free radical species generation, help prevent acidosis, and help prevent disruption of the blood-brain barrier. However, therapeutic hypothermia in any context comes at a cost. You're more likely to see bradycardias and other malignant cardiac arrhythmias. Electrolyte abnormalities are common. Platelet function is impaired and coagulopathy does occur. The immune system is depressed and common intensive care infections like pneumonia become more of a problem. You see reduced insulin sensitivity and blood glucose control can be difficult, and very prolonged effects as a result of decreased clearance of sedative drugs. It was back in the 1940s that we first noticed the deleterious effects of cerebral anoxia on brain volume, and it was the 1950s when people started to notice that cooling could affect brain blood flow and therefore reduce brain volume. And it was also in the 1950s that there was a suggestion made that cooling may be of benefit to the patient post-cardiac arrest. This was the original study, published back in 1959 in Anesthesia and Analgesia. This study doesn't really match what we think of as a proper randomized controlled trial these days, but it's still interesting to have a look at what happened. They took 27 patients who'd suffered a cardiac arrest, immediately were able to exclude 8 of them as they were perfectly healthy post-resuscitation, which begs the question, did they really suffer a cardiac arrest? 7 of them were not cooled, and 12 were cooled within 6 hours of return of spontaneous circulation to 31 to 32 degrees Celsius. In the group that were kept at normal temperature, only 1 out of 7 survived, and in the cooled group, 50% survived, and the survivors had no neurological deficit noted at the time. We had to wait until the late 90s to see further trials conducted, but most were published in the early 2000s, and there were 2 major trials, both published in the New England Journal in 2002. The Bernard et al. Trial looked at 4 hospitals in Australia based around Melbourne. They included men over the age of 18 and women over the age of 50 to minimise the risk of cooling a pregnant patient. And they only took patients where the initial presenting rhythm of cardiac arrest was ventricular fibrillation. All these patients had had return of spontaneous circulation and were still in a persistent coma after that return of spontaneous circulation. They excluded patients who had cardiogenic shock or a different likely cause of coma, such as drugs or blunt trauma to the head, for example. They were randomly assigned to either standard management with or without cooling. Cooling, when it was used, was started by the paramedics, and they used ice packs to do that. By standard management, they talk about correction of cardiovascular instability, invasive ventilation, sedation with midazolam, and muscle relaxation with vecuronium, fairly normal levels of oxygen and carbon dioxide tension, a slightly higher than normal for these days anyway, mean arterial pressure of 90 to 100 millimeters of mercury. They used thrombolytics. Remember, this is the day prior to primary percutaneous intervention for the heart, if required, and heparin. They used lidocaine as an antiarrhythmic, kept potassium levels above 4. They gave insulin to patients to keep glucose under control, and everybody got aspirin. They cooled people to 33 degrees, and packs were at that point removed. Patients were kept paralysed to prevent any shivering and kept at 33 degrees until 12 hours after they arrived at hospital. They were actively rewarmed from 18 hours after arrival at hospital, and if they had not made any form of neurological recovery, care was withdrawn at 72 hours. They considered a good outcome to be normal to moderate disability. Although the overall numbers are fairly small, there is quite a clear difference in outcome here. In the group that were cooled, almost 50% had a good clinical outcome, and in the group who were not cooled, only a quarter of patients had a good clinical outcome. The next major trial that we saw was the hypothermia after cardiac arrest group. They looked at adult patients who'd had a short downtime, less than 15 minutes until CPR had begun, who had a witnessed arrest, and they also took pulseless ventricular tachycardia as well as VF patients. But remember, these are shockable rhythms only. They had to get an output back within an hour, and they excluded anybody who was hypothermic on admission, who was already in a coma before arrest, who was hypotensive for a prolonged period post-arrest, or who was hypoxic for a prolonged period post-arrest, and those with terminal illness and severe coagulopathies. It was a randomized, blinded outcome controlled trial where people got standard therapy or standard therapy along with cooling. Standard therapy involves sedation for 32 hours. They don't make any comment in the trial on acute coronary syndrome treatment, but I would imagine that was part of the therapy. And the cooling target was 32 to 34 degrees Celsius for 24 hours, and they then allowed passive rewarming of the patient. Their primary outcome was a favourable neurological outcome, and they defined that as a Pittsburgh Cerebral Performance Category 1 or 2, people with good or moderate levels of disability. They looked at a whole series of secondary endpoints as well, including 6-month mortality and lots of complications as well, such as bleeding, pneumonia, sepsis, pancreatitis, etc. Slightly larger trial than the Bernard et al. One, but again, they found a significant improvement in neurological outcome in the group that were cooled. More than 50% had a favourable neurological outcome if they were cooled, and only 40% had a favourable neurological outcome if they weren't. The risk of death was also reduced from 55 to 41% if people were cooled. I apologise for the quality of this slide, but what it does show is the secondary complication rates that they were looking at. And if the hypothermic group, you can see that there was more bleeding, more pneumonia, and more sepsis in patients who were cooled versus not being cooled. In 2010, we had a Cochrane review published, which was based on 5 papers, including the 2 we've just looked at, and it concluded that conventional cooling methods to induce mild therapeutic hypothermia seem to improve survival and neurological outcome after a cardiac arrest. Off the back of that, a large number of governing bodies such as the Resuscitation Council, the American Heart Association, produced to suggest that considering it for non-shockable rhythms as well. So everything seems pretty clear, doesn't it? Cooling is a good thing. But in 2013, the targeted temperature management trial was published in the New England Journal. The background to this was we didn't really know what the target temperature for cooling patients should be. And in some of the trials included in that Cochrane review, in particular the hypothermia after cardiac arrest study, the standard treatment arm with a lot of pyrexia in that group following arrest. So was cooling the source of benefit, or was it just the avoidance of pyrexia? In terms of the patients they took adult patients who were comatose on hospital admission after return of spontaneous circulation following an out-of-hospital cardiac arrest. They took patients with any presenting cardiac rhythm, but a presumed cardiac cause of arrest, and the patient must have had at least 20 minutes of stable spontaneous circulation following successful resuscitation. They excluded people who had had at least 2 hours between return of spontaneous circulation and screening to include in the trial, and they also excluded people with unwitnessed arrests who had an asystolic presenting rhythm. They excluded people with suspected or known cerebral vascular accident or intracranial bleed, and those who presented with a core temperature less than 30 degrees Celsius. It was a multi-center study, and people were randomly assigned to either 33 degrees therapeutic hypothermia or the avoidance of pyrexia arm, target 36 degrees. Obviously, the treating clinicians were aware of the trial arm, but the investigators and those performing neurological testing and prognostication were not. People were cooled rapidly using various methods to a target temperature for 24 hours, and then allowed to gradually rewarm to normothermia. Sedation was switched off at 36 hours, and people were kept pyrexia free, that they define as less than 37.5 degrees Celsius, until 3 days following arrival in hospital. If they were still unconscious at the end of this, they had a full neurological examination and a recommendation made regarding continuing care. In terms of outcome measures, their primary outcome measure was all-cause mortality at 6 months after enrolment. They needed 900 patients to achieve the adequate power for that outcome measure. And secondary outcome measures were people with poor neurological function, mortality at 6 months, and any adverse events. In terms of their outcomes, as you can see from this slide, there was no difference between the groups that were cooled and the groups that were just cooled to avoid pyrexia, and that includes all-cause mortality and neurological outcome. They also noted more adverse events in the hypothermia group, although that didn't achieve statistical significance, and more hypokalemia in the hypothermic group, which did achieve statistical significance. The causes of death were very similar between the two groups. So in conclusion then, they found no benefit in cooling people to 33 degrees over just avoiding pyrexia. So where does this leave us then with the post-cardiac arrest patient? Well, the number one thing is that all patients must meet the standard ICU admission criteria. They must have a reasonable physiological reserve to survive, a reasonable chance of reversibility of their acute pathology, and the ability to rehabilitate to an acceptable quality of life as far as we can ascertain. We should be taking all post-cardiac arrest patients that meet these criteria and sedating them for approximately 24 hours with cooling to avoid pyrexia. Now locally, we target 35 degrees, and that's because we know from our own audit data of post-cardiac arrest patients that what we actually achieve is usually 1 degree higher than our target. Acute coronary syndrome treatment should be given as indicated. We turn our sedation off at approximately 24 hours, and we maintain normothermia for a further 2 days following that. Locally, we look to prognosticate post-cardiac arrest at around day 5 in most of our patients. This is primarily by a clinical examination, which obviously includes GCS, pupillary and corneal reflexes. We do also use neurophysiology monitoring with EEG and occasionally somatosensory evoked potentials. And I do believe there is a role for neuroimaging to give a structural reason for the clinical findings we're getting, such as hypoxic brain injury, for example. Earlier prognostication is certainly possible under certain circumstances. Clearly, if your patient is brainstem dead, there is no need to continue for 5 days prior to prognosticating. Also, absence of the N20 peak on somatosensory evoked potentials, especially in the context of low motor scores or severe myoclonus, are both indicative of a very poor neurological outcome. If a patient has status epilepticus and despite treatment still has status epilepticus with a low motor score, again, that's a very poor prognostic sign. And if the motor score remains 1 to 2, I would advocate daily re-examination and withdrawal of care if that does not improve, and any metabolic or pharmacological problems have definitely been ruled out. In conclusion then, while there are many theoretical benefits from cooling, I think we've shown that it's probably the avoidance of pyrexia that's of benefit to our patients. We've gone through a brief history of cooling, and we've looked at what we do locally for post-arrest care in light of that targeted temperature management trial. I hope you've enjoyed this short video. If you do have any questions or comments, please leave them down below, and I hope to see you on the next one.